Well, welcome everybody. I want to thank Dana and everyone who made it possible for us to actually have the conference this weekend. This is my first time with SoMeDocs, and I am absolutely impressed by the caliber of this group. I have never met so many in one place who had the entrepreneurial spirit and the energy to go ahead and deliver the projects. And I'm especially grateful that so many of you are actually here on a Friday night at 8:30 listening to my lecture on value-based care, and hopefully it'll be useful to you. And I am available, as Dana mentioned, for the rest of the weekend to answer your questions in our pop-up conference space, and you can always ping me through Facebook Messenger and any other way. So let's get into the ABCs, which is sort of my own little proprietary framework here of VBCs. And of course, VBC stands for value-based care. And I think that if you're an entrepreneur in 2023, whether you are developing a product, developing a service, running a practice, working for an academic healthcare system or insurance company, you do need to know what value-based care is, because it's growing very rapidly. I'm sure most of you have seen some headlines about Oak Street Health in talks or inching toward being purchased by CVS. Oak Street Health is one of the well-known Medicare Advantage primary care providers, and that's a type of value-based care. And this is $10.6 billion acquisition that is going to expand CVS footprint across multiple offices and allow them to tap into Medicare Advantage population. So a little bit about me. I'm a cardiologist. I am and have been practicing precision medicine. This is stuff that is based on integrative and lifestyle medicine. I'm also a digital health expert and a practice model innovator. I completed a dual degree, Exec MBA and Masters of Science in Healthcare Leadership at Cornell. And shortly after that, I ventured into value-based care space. So today I have three objectives. I want to make sure that everyone knows what value-based care actually is. I want to introduce you to the framework that is going to help you to evaluate how to make your service, your product, your idea, your entrepreneurial concept have some traction in value-based care space, because that's actually pretty difficult to do. And I'm going to do it through the lens of a case study. One of the things about the business school that I absolutely loved were the case studies, and getting my team to debate those and producing our reports. And I think this is a very useful exercise in the entrepreneurial space to actually look through the lens of real experiences. So far in my role with the value-based care organization, I looked at about 20 companies. Some of those companies I actually reached out to. There were colleagues that I felt had useful products for our space. Other companies have approached us. So I think this will actually resonate with many of you who have services and products. So this is our case study. I'm going to mention a couple of points throughout our presentation, kind of lay the groundwork, and it could be any company. This is actually loosely based on one of the companies in the space, but it could be almost any product or any service. This happens to be a digital health company, and the company is seeking to gain traction in value-based care space. They provide a service that has to do with remote care monitoring. They're focusing on chronic conditions, heart failure, hypertension, COPD. They have documented good progress research-wise, the fact that their product actually works and it achieves its goal. It has a favorable impact on some very important criteria, such as medication adherence for patients and reducing readmissions. And of course, as most technology companies will tell you, if you interacted with vendors and entrepreneurs, they're very passionate about their products, and they feel that their products are absolutely the most essential thing that your organization needs to have. And so the question then is, how do you size up this opportunity? Because in a large organization, it's not just about having the research data or documented favorable outcomes. In a value-based care space, it's about creating value. And I hear this from physicians all the time. What actually is value, right? If value is part of value-based care, what actually is it? And the concept itself was brought forward in 2006. It was based on a seminal work of Michael Porter and Elizabeth Olmsted from Harvard Business School. And the book was called Redefining Healthcare, Creating Value-Based Competition and Results. If you're a student of business strategy, you will know that Michael Porter is the father of business strategy. He created very powerful framework, defined Porter 5 forces. He speaks a lot about sustainable competitive advantage. And so this was Dr. Porter's work that attempted to reformulate healthcare as we know it, recognizing that for decades, 50 plus years, there's been limited of any innovation in healthcare, and healthcare delivery was really not meeting the needs of the patients or the practitioners who are practicing healthcare. And so in a series of articles, as well as the book, Dr. Porter put forward his vision as to what should be the framework for value-based care. He defined the framework as organizing or integrating medical practice, not based on siloed or specialty care and episodes of care, but based on patient conditions and patient centricity. And his proposal was for something called integrated practice units. And he proceeded with his co-authors to define how to measure outcomes and cost, offered an idea for bundle payments, expanded it into a multi-site, geographical, integrated care delivery system, as well as highlighted that to accomplish all of this, we need a technology platform. Now, that sounds pretty great, doesn't it? But in reality, it's actually fairly difficult to execute. The major concept that I want everyone to know is that in the value-based care space, value is a relationship between quality and cost. As the quality of care increases, the cost actually drops. And therefore, you could see it, it's basically just a simple mathematical formula, quality over cost. If the quality is high and cost is low, we have a high value service or a high value organization. And this is probably the most difficult part of the value-based equation. We can produce very high quality outcomes. Of course, we have to define what those outcomes are, but what is the cost? And for me in particular, for example, I practice a lot of precision cardiology where patients come in who wish to undergo or take advantage of lifestyle interventions that may help them, for example, to reduce reliance on medications, to lose weight, to reverse some of the cardiovascular conditions and risk factors in a natural form. And as you could imagine, most of this type of intervention falls into the concierge domain, so it's not going to be covered by insurance-based medicine, and it will require a patient to pay out of pocket. And so there could be expense in, let's say, several hundred or maybe a couple of $1,000s. But on the other hand, even though the patient is footing the bill, it actually improving their overall level of health and results in extraordinary quality of outcomes, with the patients not being admitted and not suffering major adverse cardiac events. So a lot of the doctors in this precision medicine space, integrative space, do highlight that they have excellent outcomes. But the question always is, at what cost? And so healthcare, as you know, remains truly a global issue, and I would say actually a global problem. Because when you look at developed nations, United States leads developed nations in terms of healthcare expenses as a percent of its GDP, and actually lags behind many other nations for health outcomes. The other developed countries are not necessarily too far behind. You could see that most of the countries on this slide, a very sizable proportion of their gross domestic product is actually used to meet healthcare expenses. Now, if you're a practitioner, if you're a physician, a nurse, entrepreneur in a healthcare space, without a doubt, you have encountered these solutions, you have heard these buzzwords. At one point or another, these solutions have been proposed as the solutions that are going to move the needle, right? Bend the cost curve, allow us to spend less while improving our outcomes, whether it's evidence-based medicine, error reductions, all sorts of rationing, such as prior authorizations, introduction of electronic medical records, diffusion of medical care into more of a consumer domain, patient as customers, maybe minute clinics by CVS, of course, all sorts of consolidations that we're seeing in the healthcare space, personalization of medicine, obviously very close to my heart because that's what I do, or even big data analytics, such as IBM Watson, for example, right? So all of these solutions have been proposed as an opportunity to improve healthcare delivery by improving outcomes and reducing cost and therefore improving its value. However, we have not really had a chance to see a remarkable improvement that everyone wishes for. And of course, you know, in a third year period, in maybe what you would call a post-COVID period, one could say, well, we really see how exposed and vulnerable and fragmented our healthcare system is. So it's definitely time to restructure healthcare delivery. So a lot of practitioners and, you know, being in that lifestyle medicine space, I get inquiries from lots of companies, and some of them have products or they have services or they have health coaching, and they usually lead with, we produce great outcomes, right? And so great outcomes are fantastic. But remember how I said the formula is outcomes over cost. So the definition of value-based care cannot be understood at the level of a hospital or a practice or a specialty or even a product. You have to zoom out and say, well, what is the full cycle of care and how does my hospital, practice, physician, service, product deliver outcomes for the condition that matter to patient at the acceptable or competitive cost. And that's really the type of a mindset that one needs to have in order to understand how to create value in healthcare and also how to measure it. So this concept of patient and condition centricity is the fundamental concept. And as entrepreneurs, we need to understand this, that we are not organizing our solutions or shouldn't be organizing our solutions around a specific condition or a specific organization. We should be organizing our solutions around the customer need. And so in most situations, a patient is a customer. That's why I put it in quotation marks, because there are certain outcomes that matter to a patient very much. And in organizing the solution, we have to include a very full and comprehensive offering that spans all of the levers of the cycle of care. And then the solution will be usually a good fit for value-based care domain. Dr. Porter outlined this concept in subsequent article. I gave you a lot of references, and I have some references in my slide later on separately, kind of to really get you thinking about it. The most important step in the value-based care framework is the integrated practice unit. Now, integrated practice unit could be a physical practice, or integrated practice unit could be your product or your service that falls within all these categories that enables organized intervention around a medical condition or defined patient segment, enables care delivery that is multidisciplinary and dedicated to that specific condition and patient segment. It is something that could stand up on its own as the common organizational unit, where the team consists of both clinical and non-clinical members that could take responsibility to act. it includes a lot of other moving pieces: education, engagement, administrative and scheduling structure, geographic reach, and even a local champion to champion this care delivery model. Now, the question always comes up, how do we measure true outcomes? Now, remember the company that I mentioned in the case study. Remote care monitoring solutions are very common and very popular. And indeed, there is good literature supporting that some of them, not all of them, are able to achieve good outcomes. But what actually are the outcomes? In the 2013 review in Harvard Business Review, Porter and his colleagues have defined it as 3 tiers, and I took heart failure example and I adapted Porter methodology to that heart failure example just to show you kind of the thinking process, right? So health status achieved or retained is considered tier 1, and this is what typically is described as care cycle. Tier 2 is the process of recovery, which is a care process. And tier 3 is sustainability of health or sustainability of recovery. And that's sort of a care guarantee, like a guarantee on a vehicle, for example, that you may be driving. And so these outcomes, they may look somewhat familiar for certain things, but overall, they probably not, because the lens here is a patient's perspective. What is important to a patient who is diagnosed with heart failure? Well, of course, mortality rate, the ability to recover their function. If they have been impaired due to their cardiovascular illness and if their functional class is low, can they recover some of the function in the process of being treated, for example? Avoidance of hospitalizations, the process of treatment itself, anxiety, treatment complications, medication side effects, if they're admitted, lengths of stay, or the probability of readmissions. And once they are treated, and let's say there was an admission, they're discharged from a hospital, what are they likely to expect in terms of their recurrences, their long-term consequences, and how long do they have before the next admission or before the next deterioration? You could see that these are very difficult outcomes to measure. Now, outcomes have a hierarchy. Obviously, tier 1, the care cycle, a lot of it is about degree of recovery and survival, while tier 2 is more about the patient experience, time to recovery, time of return to their normal activities, and tier 3 is more of a durability or guarantee of success. And there are actually healthcare systems now, like Geisinger, for example, that actually guarantee their patients a certain plausible result for conditions that are following the value-based care model. For example, heart failure, and guarantee of not having a hospitalization within a certain period of time. So we in healthcare, though, are still, majority of the time, are not dealing with outcome measures. We're dealing with process measures. And this is what everyone knows. And this is usually at the core of the reimbursement models, right? We talk about the adherence rate for guideline-directed medical therapy, patient's weight and blood pressure, so-called HEDIS measures. And those of you in the value-based care space will know what those are. And they could be meaningless. For example, heart failure patient who is a diabetic, one of the HEDIS measures could be the control of hemoglobin A1C, which is important, of course, but through the prism of heart failure, not as important as the true outcomes. Of course, we can have some other measures: length of stay reduction, ER waiting time, infections, readmission rates, appointments eligibility and availability. But these are process measures. These are not true outcomes. And so defining outcomes is more difficult than we realize. There is actually an international society that does it, and it says for International Commission on Health Outcomes Measurement. Membership is free. You can go on their website and sign up even now, and you could see that there has been a bunch of standard sets created by experts from multiple countries. So they are not just based on the United States. They include developed countries and developing countries and very diverse patient populations. And the goal is to define what actually matters to a patient, what matters for a condition, what questions should we be asking, and how should we try to derive at a common denominator that allows us to separate true outcomes from the process measures. One of the examples, since we're dealing with heart failure startup, is actually heart failure, and this is patient-centered outcome measures for heart failure from iChum. And you could see here that it includes symptoms, it includes perceived quality of life, including maximal physical exertion, even patient sense of confidence and self-esteem, as well as their depression and anxiety scores, and of course, things such as admissions, appointments, and so on. So it's a very multidimensional, vibrant model that, as comprehensive as it is, it's certainly recognizable that measuring these outcomes in most routine clinical encounters is a challenge. And of course, if outcomes are difficult to measure, cost is even more difficult than outcomes, right? And that's a denominator of our value-based equation. If we have great outcomes, but the cost is very high, our value is actually low. And so the cost measurement is not just the sum of charges that Medicare or some other insurance carrier has to pay. It's the actual expense of patient care, both direct and indirect costs. And to compute that, one actually has to go away from the existing cost models that most of us are familiar with, whether it's RVU model or a model based on insurance submitted charges. The cost actually attempts to measure each patient condition through the entire care cycle and to say, okay, what are the resources that we're using? How much time is allocated to these resources? What is the actual cost? Sort of like almost like in the factory-like setting, right? Even though no one likes this comparison, but we're trying to be very comprehensive and very deliberate. And we're doing it by mapping out the care process. And so this is one such care process. In this example, this is a pre-surgical office visit, right? You could see that the orders here have gone through the length of spelling out every single step that has to happen during pre-surgical office visit, how long it may take. Those are little circles, the bubbles there show you the time, who will do what, right? So each unit, so to speak, of this entire process. And that actually gives you a comprehensive approach to how much this may cost. Now, there is a lot of barriers to overcome when one tries to do something like this, because in healthcare, we're notorious for confusing cost with prices, right? So currently, when doctor's expenses or nurse expenses are allocated to patient care, it is done based on insurance charges or relative value units. None of these are actually a good surrogate to what the total actual cost is, right? And the costs, for example, that occur for things that we cannot bill for, does comforting your patient and stopping by their room to exchange a few words and to be social, even though you already know that nurse practitioner around and them today, that's not really billable. A phone call to a patient's family, some of it might be billable now, but most of it is not. Speaking to your colleague in a hallway or by phone to exchange information about a patient, get a peer consultation, that is not really billable, but that actually costs your time and your effort, and therefore should be factored in as type of this full cycle, right? Very often organizations are involved in the wrong units of how they measure it, and administrators think that this is just fixed, right? The doctors should be like workers on the assembly line doing exact same thing over and over and over again. And that's really the concept put out there by relative value units. But as you and I know, patients are complex, and so are the physicians, and each encounter is different, even if it is for the same condition. And so very smart people have put out this idea of time-driven, activity-based costing. And if you are an entrepreneur and you're coming into value-based care organization, and we're going to go through this process in a minute, and they're asking you, well, how much will your service or your product or your effort cost us? think very carefully about how you're going to answer this, because if you're not using activity-based costing, your cost may be either too high or too low, and you may not necessarily resonate with the organization because the organization itself may not understand activity-based costing process. And for those of you who've gone through business school and who took managerial accounting, it was a really tough course, but I have to say that, professor said we're going to use it more than anything else, and he was right, of course, 100%. Now, with all of this, there are major cost reduction opportunities in healthcare, and they're important for the doctors because we as physicians and all skilled practitioners need to practice at the top of our licenses. We need to put forth processes that allow to reduce variation in complexity, because if we're treating every patient quite differently for a similar condition, undoubtedly our costs will rise. We have to delegate or eliminate low value, non-value added services, and certainly match our capacity with our demand, as well as introduce things that allow us to reduce duplication, waste, abuse, fragmentation, and potentially expand into things that are more automated or have less friction, such as telemedicine visits, for example, for certain things. And overall, when you put it all together, the cost reduction opportunities are actually quite significant. Up to 30% of the cost could be slashed off, and probably even more. Now, this is usually not popular with docs, and everybody cringes at bundle payment, but bundle payment is the number 3 in Michael Porter's diagram for value-based care. This is really highlighting the need to have a single risk-adjusted payment for overall condition, not just a procedure, not just different to a cardiologist and different to endocrinologist and different to a dermatologist, but for the full set of services that is delivered over the care cycle or over defined time period, and usually primary care, that usually in a primary care setting where we speak about value-based care most of the time, right? So it is contingent, of course, on condition-specific outcomes, including taking responsibility for avoidable complications. And we already have some of these value-based care payment models by Medicare, for example. And of course, the important part here is attribution, right? How do we exclude things that are actually not related to the cycle of care or the care process or the care guarantee? And perhaps those are some other extraneous experiences. You could see that this could get fairly difficult. Now, the models are in place. They're coming from unusual places. Walmart, for example, has a bundle payment model. They execute it in conjunction with some of the top healthcare systems. You could see them here. These are all very large and storied institutions. And actually, Virginia Mason has a great example of executing value-based care using this integrated practice unit for back pain, showing remarkable results in terms of improved patient outcomes and cost savings. So most recently, and actually it was just maybe 2 or 3 days ago, I think, New England Journal of Medicine, it has a publication called Catalyst, which I would highly recommend. It's a subscription-based model, but it's definitely worth your money because there are really great pieces from real life experiences. The most recent one was this discourse on how to create a system framework for value-based care. And also there was a very interesting article from the Google executives on how they learned to leverage their clinical staff during the coronavirus pandemic. So what's interesting about the newer framework, which was not authored by Michael Porter, but was authored by actually actually Stephen Larson, who is the president of the International Commission on Patient Outcomes Reporting, the one I showed earlier. The authors identified that there are currently 3 crises that we're facing in healthcare. Of a crisis of value, because the cost growth is unsustainable, and there's a huge disconnect between the outcomes and the cost, and there's a lot of waste and abuse in the American healthcare system. A crisis of evidence, which is a disconnect between research and practice. And we all grew up with this. We know that it takes on average 17 years for any new research to even begin to reflect in clinical practice, as well as the lack of adequate decision support for clinicians in the front lines. And the one that will resonate with a lot of us is a crisis of purpose, right? Clinician burnout, moral injury, demoralization of clinicians who are being pushed into the corner, who feel like they lost control over the situation, and who are asked to do more and more and more with less, their internal suffering and suffering of our patients. And so to overcome this, the authors are proposing this interesting moonshot schema where focusing on population segments and segment-specific interventions, they're calling on healthcare systems and organizations to create a model that continues to focus on benchmarking, cycle delivery, care process, marry the payments into it, and create informational backbone as well as a policy backbone to allow this to execute. So very interesting article, and I encourage you to read it. And so this moonshot initiative really rests on 3 important buckets: institutionalizing outcomes measurement, the true outcomes that I showed you earlier, not the process outcomes, aligning value-based payments with health outcomes improvement. If you do better, you get more, and investing in a 21st century digital health infrastructure. So any entrepreneur, whether you are delivering a service, developing a product, creating a new care model, you need to keep this in mind, because the value-based care right now is growing very rapidly. Almost half of all Medicare beneficiaries are already enrolled in Medicare Advantage plans, and that's a type of value-based care plan. So let's come back to our company, and I'm going to focus on heart failure as an example. And so let's focus on the framework that can allow you to evaluate this company. And it's, you can call it a startup, although it's in a growth space. Let's assume that they have all the adequate resources and funding to get it done. And so what I created for you is actually, it was supposed to have been ABC, but it's actually ABCDEF framework, because as I was thinking about it, more letters came to mind. So hopefully you can bear with me, and I absolutely promise 100% I will leave 10 to 15 minutes to answer questions in the chat and whatever questions pop up. So what is ABCDEF? Well, A is for ACO, Accountable Care Organization, and that's a form of value-based care organization, usually focused on Medicare beneficiaries in traditional Medicare programs. There is also Medicare Advantage, so A is for Advantage. This is Medicare Part C, which is a capitated type of a model, as well as a value add, right? So what is the company, a product, an entrepreneur adding in terms of value to a value-based care organization? B, business model and business case. C, cost of the product or service and how it fits into the care cycle and process. Will some new competencies be required by the organization in order to execute on the product or a service? D, Part D is also a big part of capitated models or value-based models. It has to do with medications and the cost of medications. And we know how egregious the cost of some medications is in the United States, as well as directionality. Is your product or service aligned with the organization that you're pitching to? Is there a digital divide that organization will have to overcome, either for its providers or its patients? And the digital divide is a real thing and could be quite painful. And what is the differential advantage of your company or product for value-based care space? E is for engagement and externality. You may have the best product under the sun, but if it takes a lot of time and effort for the stakeholders to engage with the product, chances are it will not be successful and will not deliver on its value for your stakeholders. And be mindful, if your product creates some unforeseen externality. For example, if my company sends you a patch that your patients will put in their chest to detect a new atrial fibrillation, which should be a good thing, because if you detect atrial fibrillation, you can prescribe the right medication and avoid the chance of a patient having a stroke. But what if the externality is such that a patient receives a message stating that they might be in atrial fibrillation, and being very concerned, a patient then presents themselves in the emergency room? That is not likely to improve your outcomes or to decrease your costs. So be mindful of the externalities that your product or service may potentially present in the workflow that you're proposing. And F stands for feasibility. Some organizations will be ready to execute on your product or service, but sometimes they don't have internal infrastructure that could actually support it. So, if it's not feasible to have the product or service at the moment, think about how you can modify your product, modify your workflow to account for organization having some feasibility challenges. And so we covered this. If you're in the ACO Medicare Advantage model and you are bringing a product or a service forward as an entrepreneur, you have to ask yourself, where does it add to value? Is it quality, cost, or both? B, you need to ask yourself, how is my business model translate into organizational business case? For the company that I showed you before, I had to build the business case here, and you could see that this is a care process. I had created an integrated specialty care team that was composed of several practitioners to enable to execute on the business model of our organization and to have a coherent business case for the remote care monitoring vendor. I had to create C, care cycle, and evaluate its cost. And the care cycle had to specify step by step a process map of how practitioners will actually be using the information from this service and a product, and the company has both a service and a product to allow for this remote care monitoring for heart failure. How would that actually happen? What would be the steps? My doctors and nurses will need to review real-time data, make a decision on the appropriate types of therapy, and on heart failure domain, we have all these acronyms, GDMT, CDMMT, which basically they're the same thing. They're just complete medical therapies specified by heart failure type. What would be the next steps once the patients are actually treated? At what point will they be referred to cardiology or to other services, for example, such as palliative care? How would that impact the case management for the nurses that go and help patients after hospitalization, or help patients who have difficulties engaging and be compliant with medications? And how will that factor into the transitional care and discharge, as well as the facilities that we collaborate with as part of that value-based care model? So you could see it's a pretty complicated care cycle, and the cost accrues to us as an organization at every step. And so as part of this exercise, and this is something that as an entrepreneur coming forward with a product or service for value-based care, you need to bring with you the numbers. And, the company that was working with us, we worked with them together, but you have to make certain assumptions, and you have to build your business case that not only maps out your care cycle, but also gives you a certain measurement stick on where your costs will be. And here in this example, looking at 20% of our highest risk patients, we could estimate that our total costs on what's called PMPM, per member per month, And that's sort of, the ultimate jargon of value-based care. How much cost do you accrue for each member enrolled in your organization on a monthly basis? You could see that these costs will drop. Now, that may not seem like a lot, but I can tell you that it's very difficult in the current environment of escalating costs to actually depress your costs even 3%. It takes a lot of work. I also had to work with my doctors to understand, do they have the requisite competencies? Because when I were to give them the real-time data and bring the remote care monitoring company vendor validated assessments and educate them on the standards of care, education itself is not sufficient, because you have to have a competency as a team and as a practitioner to deliver on this framework, because at the end of the day, it has to be right care, right patient, right time, and by the right team. And only under those circumstances will you improve outcomes and reduce costs. So all the pieces of this equation have to fall together. And so I had to map out the competencies for my clinicians, bin them into the categories that the doctors could understand and identify with, and go ahead and educate them and raise their competencies so that we can actually get the remote care monitoring in place and use it successfully. And then, of course, we talked about a couple of other letters that I ended up sort of adding at the last moment. And that's, of course, directionality, divide, and differential. Digital divide for this project was serious, because we really didn't have a capable digital entity to be able to give us seamless integration. We needed some additional development on the IT side, and we needed to define directionality, right? How we're going to move the project in each particular location from place to place to place. How would it be implemented? And of course, the differential component here was that we would go away from sort of homemade, types of monitoring where maybe one patient has a scale and another patient doesn't. And we would use things that are vetted and verified, and use the SMART goals. And I know Stephen mentioned SMART goals in your previous lecture, but this is a very common business framework so that we can understand how we can improve and achieve on these important metrics that we are actually seeking to deliver. Now, I learned in the process of executing on this project in my value-based organization that despite all of these pieces being in place and working, very hard to create it and implement this, engagement was actually a bottleneck, because some of the practitioners that I work with were highly engaged, and then other ones really didn't feel particularly in love with this idea. And so then I had to ask myself, well, what do I need to do for these doctors to foster the engagement? And some things were outside of my control. For example, building a new structured note in a medical record is not something that I can do. Some of the things were under my control, such as getting the doctors into virtual heart failure rounds for those patients and leveraging this entire framework to help them identify specific patients and be very deliberate in what they could do with those patients. And of course, externality and feasibility. I found that in some of the regions where we executed on this project, it was challenging because we didn't have an external partner that could help us. And what could external partner do? Well, external partner could be a cardiology group that is willing to see a patient in the emergency room and actually push a diuretic and discharge them as opposed to admit them, right? And that's a big deal for a value-based care organization, because every dollar counts. Of course, things such as capacity mismatch, mismatch. Sometimes, coming into a specific location, and we are, ChenMed is a large organization. So coming into that specific location, we could find that we didn't have enough of the capacity or enough of the bandwidth at the moment for our doctors and nurses to execute on this. And that goes back to that feasibility determination that I mentioned earlier. So I know it's a lot of information, and I know I talk fast. As promised, I'm going to stop here. I see a lot of questions in the chat. I'm going to either wait for Dana or put on my glasses and I'm reading them myself. I gave you references on the slide in case you want to read certain things on your own. And I would absolutely recommend reading maybe at least just like one thing and value-based care, because if you're not designing your product or a service for value-based care right now, you unfortunately will not secure a good market grip. So keep that in mind. And if you wish to contact me, there's my cell phone number and my email, and I'll open to the Q&A.